And Terry, I think everybody is in from the.
Should be good to start whenever you want. Yeah.
Okay. Perfect. Okay, so I'm going to sort of say good morning and welcome everybody to the 2023 Bigelow lecture. Like I know most people are online, so welcome to you all. Like whether in your office or your bedroom. Like we are very pleased to have a sort of distinguished Bigelow lecturer who's going to be speaking to us today on a topic that is of great significance to all of us, in whatever branch of surgery and in fact in whatever branch of medicine in general. Like so, this is, as you know, the the most important academic event of the year for the Division of Cardiovascular Surgery at the University of Toronto. As we start, we acknowledge, as always, the land on which the University of Toronto works. For thousands of years, it's been the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit. And even now, it is still the home to many Indigenous peoples from across Turtle Island. So we're always grateful to have the opportunity to work on this land. So this lecture is named after Dr. Bill Bigelow. And so Dr. Bigelow was born in Brandon, Manitoba in 1913. Got his MD at the University of Toronto and was a surgical resident at Toronto General for a few years after that. During the war, he's actually served in the Canadian Royal Army Corps, and from 41 to 45, initially at the Field Transfusion Unit and then subsequently as a battlefield surgeon in Belgium. After the war, he returned to Toronto General and then spent a year at Hopkins in Baltimore with Dr. Alfred Blaylock. And it was around this time that he sort of first conceived the idea of using hypothermia to protect the brain and the body during cardiac surgery. So the first operation that was performed under hypothermia was done in a dog in 1949. And this paper was presented at the American Surgical Association meeting in 1950, caused quite a bit of stir, as you can imagine. It really was a revolutionary concept at that time. Again, in the subsequent years, Dr. Bigelow sort of discovered the principles of the electrical pacemaker. And it's those two contributions to cardiac surgery, hypothermia and the pacemaker, for which he has become most known. He established, the first division of cardiovascular surgery in Canada here at the U of T in 1953. And for his lifetime of achievements, he was recognized as the president of the American Association for Thoracic Surgery, our most distinguished academic society in cardiac surgery in 1974. Over his lifetime, he trained 3 generations of cardiac surgeons who have gone on to leadership positions across North America and the world, and he accumulated a total of 25 major international and national awards, including the Order of Canada and the Canadian Medical Hall of Fame. And if you Google Dr. Bigelow, he still has an outsized presence on the internet. These are some of his images, including from the Canadian Medical Hall of Fame. But one of the sort of lasting contributions, which all of us have read, is this book, which really documents his experience during that time with innovation and sort of developing these 2 principles. And one of the great quotes from this book, and one of my favorites, which I think gives the measure of a man, is this one. Humility is an open-mindedness which is acquired by an understanding of the meager state of our knowledge in relation to the vastness and elusiveness of the ultimate truth. So it really sums up his approach to investigation, in a nutshell. I am, as always, grateful to Dr. Bigelow's daughter, Pixie Bigelow Curry, and many members of our family who are joining us online today for their continuing support over many years for this event. So I'm very pleased to introduce our 2023 Bigelow lecturer. This is Dr. Hanneke Takkenberg, and Hanneke is the professor of clinical decision-making in cardiothoracic interventions in the Department of Cardiovascular Surgery at Erasmus Medical Center in Rotterdam. She's had a long-standing research interest in the optimization of therapeutic choices in cardiovascular disease via evidence-based and shared decision-making. And these are themes that she's going to be speaking on today, with a particular focus on valve disease and thoracic aortic aneurysms. So for her many years of work in this, she's served as the past president of the Heart Valve Society and is still a senior advisor to that organization. This is an international consortium of cardiac surgeons, cardiologists, scientists, and patients who are all dedicated to advancing the care of patients with heart valve disease. Of her many interests, free time is not one of them. So Hanneke also serves as the professor of management education at the Rotterdam School of Management. But for many decades, it's really Hanneke's passion for promoting sort of equality of opportunity that has distinguished her. And so she continues to serve as the executive director of the Erasmus Center for Women and Organizations. She's influenced sort of national and European sort of policy as the past chair of the Dutch Network of Women Professors and the Erasmus University Rotterdam, or EUR, Network for Women Professors. She's won a number of national and international prizes for her work in this area, including the Els Borst Prize, the Katie Asher Award, and the EUR Athena Award, really for advancing gender equality and inclusion in medicine and academia, and particularly addressing sort of sex and gender roles in research and leadership. So Hanneke is going to be speaking to us today on a topic of does size matter in thoracic aortic aneurysm. Hanneke, thank you for coming to Toronto. We are so pleased to have you here, and we're very much looking forward to your 2023 Bigelow lecture.
Thank you very much, Terry. It is a true honor and a pleasure to be here this morning, giving this really prestigious Bigelow lecture. And I never had the pleasure to meet with Dr. Bigelow, but when he talks about humility, I truly relate to that. And I'm also very impressed that I was actually invited here, as I saw that one of my big heroes and mentors, Maggie Cook, also gave this lecture a couple of years ago. And I thought, well, I'm really old now, I guess. But on the other hand, I could also say I'm really experienced and I have a lot of stories. And I'd like to share with you 3 of those stories today. And as you can see, the title of my talk is Does Size Matter in Thoracic Aortic Aneurysm? But I want to bring that also in a broader perspective. So I would like to talk first and foremost, I would like to tell a story about a conversation I had with one of our aortic surgeons in the hallway who made a really bad joke. And then it ended up becoming a really innovative project about looking at male-female differences in thoracic aortic aneurysm. The second thing I'd like to do is I'd like to tell the story of Tol. And some of you may know Tol, who is an individual living with Marfan, but has really inspired me to change the way I think about optimal clinical decision-making. I'll get to that as well. And thirdly, I would like to tell the story about a really great dinner I had a couple of years ago in New York City at Times Square with some of the surgeons from the Netherlands. And that led me to really realize that medicine is not gender neutral, but we'll get to that. So first and foremost, let me start in the operating room. I've had a long career in cardiac surgery, and I first started in clinic, but fairly soon noticed that research was my thing because I really wanted to improve the quality of the care that we deliver to our patients. And clinical decision-making has been a key part of that. So I built my career in cardiac surgery, always using the operating room and the clinic as a source of inspiration, because that's where the big questions are that need to be addressed, that need to be answered, and then need to be put back into clinical practice. And that's what I love to do. So I think it was in 2015, and that was at the time that especially on the American side, in cardiac surgery and in cardiology, there was a growing attention for male-female differences in the way we diagnose patients, in the way we treat patients, and in the outcomes. So at that point in time, having built a lot of institutional databases, both in heart valve disease, but also in thoracic aortic aneurysm, I thought I would take a look in my own center's aortic surgery database, thoracic aortic surgery database, because I thought perhaps there's differences in the way that we treat men and women with thoracic aortic aneurysm. And my hypothesis, and I always work together with my students and colleagues on that, our hypothesis was, well, probably at the time of surgery, the thoracic aortic aneurysm diameter is going to be somewhat smaller in women compared to men, because women, on average, are smaller than men. And then we looked in our database and we found the opposite. We found that at the time of surgery, women actually had a half a centimeter larger aortic aneurysm than men. And so we were puzzled. What could that be? Is it in biology? Is it in, does it have to do with hormones? These were the things I was thinking about. And then I ran into one of our surgeons, our aortic surgeons, in the hallway. And I said, Jos, I don't know what's going on, but I'm looking in our database and I find that women at the time of the treatment of their aneurysm have a larger diameter than men. And then he made a joke and he said, oh, I know what this is about. It's because that women are so hesitant and they like to postpone things. I'm like, okay, I'm sorry. But I'd never thought of that there may indeed also be a gender component in there. So we talked a little bit and we joked around and then we said, oh yeah, size does seem to matter, or doesn't it? And that became the title of a project proposal that we submitted to the Dutch NIH. And I gathered my colleagues across the country and asked, do you want to join? And I had the running title Size Matter for this project. And then all of them basically responded fairly fast and they said, that's a great title, I want to join. I don't know what it's about, but I would love to join this project. So we kept the title and we started looking into male-female differences in thoracic aortic aneurysm in the Dutch context. And let me see. And before I give you an overview of what we found over the past 5 years, I just want to stress on the fact that back then I had no clue about sex and gender and how it actually has multiple dimensions. And of course, biology, sex is at the center. It is in our chromosomes, and there's a lot of biological factors that may influence differences between men and women when it comes to thoracic aortic aneurysm. At the same time, we also have gender. And gender is, of course, much more fluid than sex. It's about how we identify. But it's also about the role that we play in society. It's about the relationships that we build that are gendered. And it's about the way that we build our institutions. So my talk today will not only be about sex and gender in thoracic aortic aneurysms, but also bringing it a bit further and looking at the genderedness of the systems that we work in. But let's start with thoracic aortic aneurysms. In the Netherlands, there's about 70 million people, and we know that there's about 200,000 adults with thoracic aortic aneurysm. 600 deaths each year can be attributed to the main complication of thoracic aortic aneurysm, and that's dissection and rupture. A lot of people who walk around with this disease have the feeling that they have a ticking time bomb in their chest. And therefore, I think in trying to decide how to optimally treat these patients, of course, we need to take a critical look at clinical aspects of the disease, but we also need to take a look at aspects that are more related to how patients experience their disease and how we can also help to optimize their quality of life. And that's what this project tried to do. What we basically did with 4 centers in the Netherlands, we built a really large database for starters that looked not only at operations, but also looked at patients from the time of diagnosis. And over 1,800 patients are in there. And we asked the question, first and foremost, do women present differently? Well, it's still work in progress because that database took about 4 years to compile, all in all. But the main findings that we're going to publish, hopefully early next year, is first and foremost is that women are older. That's what we knew already at the time of diagnosis. They more often have a high blood pressure and more comorbidities than men who present with thoracic aortic aneurysm. They also more often, at least in our healthcare system, present with an extremely low blood pressure. And when we look at the symptoms with which they present, more often nausea is one of them, which is really aspecific. We also asked the question, are there differences in aneurysm growth over time? And what we did here, we looked at ascending aortic aneurysm here. We did find some really insightful things. First and foremost, what you can see in this slide is on the horizontal axis, follow-up in years over time. So we repeatedly measured diameter over time, both at the sinus level and at the tubular level. And we found, after using mixed models, that, for example, in 50-year-old patients whose aneurysm is most pronounced at the sinus level, that men indeed present with a larger diameter than women. And if you look at progression over time, it's about the same. On the other hand, in the tubular part of the ascending aorta, the ascendings, you see that the starting point at diagnosis, diameter is comparable in men and women around the age of 50. But when we take a critical look at progression over time, we see that there's a tendency for women to advance faster in their disease. So these are patients at the age of 50. But how about the age of 70? So we ran another model based on our data, and we found that at the sinus level, which you can see here, the upper right picture, we see a comparable picture with the 50 years old, that men present with a larger diameter than women. You can actually see it go down a little bit over time. That also has to do with dropout of patients. But more strikingly, at the age of 70, women present with a way larger diameter than men, and also progression over time seems to be faster. And this is very interesting, because if you look at it as a whole, you don't see this happening. But right now, what we are getting more insight in, that is especially at an older age, women and men have different trajectories in the progression of their disease. Then let's take a look at clinical outcomes in our large multi-center data set. And let's start with taking a look at death before operation. In women, you can see that here, it's about 11% at 7.5 years, while for men, death before operation is about 8% at 7.5 years. Then, if we look at the probability of undergoing an operation, the green line, in women, the probability of undergoing an operation is higher than it is in men. It is 72 versus 58% at 7.5 years. And finally, taking a look at operation-free survival, we do see that this is 18% at 7.5 years in women, while it is 34% at 7.5 years in men. So quite some differences there when it comes to the natural history. Then we asked the question, do women have different treatment outcomes? And we took a particular look at the outcomes after surgery. And of course, we've already seen that women receive surgery sooner after diagnosis. At the same time, also more often have conservative treatment, especially if you're an older woman, and your thoracic aortic diameter at the time of surgery is larger, especially in older women. We also saw that more complex surgery was what women had compared to men. And if you're interested, I put all kinds of references down there for your, if you would like to read more about that. At the same time, after surgery, what we did see is that there were comparable clinical outcomes between men and women after correcting for all the differences we found in their baseline characteristics. Then, the next question we asked was, do women cope differently? And so we did some cross-sectional studies in different types of populations, including aortic dissection patients, but also thoracic aortic ascending aneurysm patients. And we found that if we look at coping with the disease, we found that women compared to men have a lower health-related quality of life. And we know that's true as well in people who are healthy, do not have disease. Oh, I see the slides do not come up. But, at the same time, we also saw that they experienced more anxiety and depression related to the disease than men did. And this affected younger patients more than older patients. Again, here's the intersection between men and women and age. Important to take that into account. Also, we found that men and women have different coping strategies dealing with their disease, with women being more communicative about it, and men being more trying to put it away, put it in a safe place, I guess. So what's next? We're at the end of our project. What we did, as I said, everything starts in the operating room and ends in the operating room as far as I'm concerned when it comes to research. We developed, and I know you can't read this, but at least you can grasp what it is. We built, based on this project, a patient information portal together with cardiologists, together with surgeons, but also with patient representatives. And this information portal, we provide information not only about the clinical aspects of thoracic aortic aneurysm, but also about living with thoracic aortic aneurysm. And we developed a handout that surgeons and cardiologists can use to help patients explain what their disease is all about. And you can actually use it to make pictures of the exact situation the patient is in, and it refers them to the information portal where they can then back home with their family take a more critical look and try to understand what's going on. We are currently testing this portal in an implementation trial, multi-center in the Netherlands, and we hope to find that patients who and family of patients who use this portal will at least have better knowledge and feel better informed, have better quality of life, and less anxiety and depression. And we're really hopeful that's going to happen. It's going to come out next year. I think that's when we're done with that. So at the end of this project, and we did more in this project, but I don't have enough time to also talk about aortic slices and what we did with them and blood and all kinds of other testing that we've been doing. But we answered some of the questions. But the great thing about research is it also brings along new questions. And I guess I put down a couple of those questions is because we didn't figure out whether size matters. We didn't figure out whether it's sex or gender. And so these are things that we need to dig in further in order to help improve the quality of care for both women and men with this terrible disease. Also, during the past couple of years, there's been a progress in thought about what is really important in optimizing the timing of treatment in this disease. And is it just the diameter? And are we measuring the right size? And are we having the right cutoff point when it comes to deciding when to treat or when to still watch and wait in these patients? So there's two really great papers that I would like you to encourage to read. First of all, there's a paper from Cleveland Clinic that came out very recently that's actually talking about whether we are measuring size correctly and whether we should not be looking at stuff like aortic elongation and some other new things that we may be able to use to better determine the optimal point in time for treatment. And then there's another paper that comes from the group of Eleftheriades, who actually says, well, we need to go down when we talk about cutoff size for surgery. But the question is, does one cutoff size fit all? Should we have different cutoff sizes for men and women? There's a large debate going on, and we even have fights about that in our own project in Rotterdam. We do not agree on that, but that discussion needs to evolve over the next couple of years. So, and then on top of that, finding the clinical optimal point in time to intervene, having patient-specific treatment is more than just getting all those clinical variables aligned. We also need to think of the patient perspective. And the picture you see here is a picture of a man from the UK, Tol Goldsworthy, who was diagnosed with Marfan. Perhaps you can see some of you can see that in his features. And when he was diagnosed about 20 years ago, he and was told that his aorta was slightly dilating, but that he didn't need surgery yet. He's like, oh my God, I don't want to wait. And he is a technical engineer, and actually I believe he is specializing in heating systems. And he thought, well, I know everything about pipes, so let me see how I can fix my own pipe. So what he did, and you can see that lying on the table in front of him, because he was teaching here about his disease, he devised something called personalized external aortic root support. And basically what he did, and you can read more into that because Tol is all over the place, and I work also with him now on several projects. He had an MRI made of his own ascending aorta, and then he designed this mesh that perfectly fit his aorta. And then the only thing he needed was surgeons to put it in. And that promised to be the most challenging part, I guess, in his journey, because intervening early on in a disease process that has a standard treatment, but later on that's well established, was quite a challenge. But he found in the UK, he found Tom Treasure and John Pepper, and actually they operated on him. He was the first patient to receive his own solution to his disease, which I think is really special. By now, more than 750 patients have undergone this more preemptive treatment. It doesn't require cardiopulmonary bypass, but you can see at the scar on his chest, it's still pretty invasive. And outcomes look pretty good. Well, Tol is, for me, an inspiration in that we not only need to take a look at clinical characteristics, but also take the patient perspective into account. Together with Tol, there's also another patient I'd like to briefly mention, who is also changing healthcare in a way. And you probably know Adam Pick, some of you. I've met him a few times now. He was in his early 20s when he received a Ross operation. And he was a major in marketing and communication. And then after his Ross operation, he started heartvalvesurgery.com. And in heartvalvesurgery.com, if you haven't been there, perhaps you know about it. On this side of the Atlantic, patients can go there, find information, but it is also become a referral point towards specialized centers that provide heart valve disease care. So that's quite revolutionary as well. So it's these patients that are telling us, hey, besides clinical stuff, we do need to put the patient at the center of what we do. And so when I look back at my career and look at optimal clinical decision-making, I know from one of the godfathers of clinical decision-making, David Sackett, we need three things for optimal clinical decision-making: scientific evidence, apply that to the individual patient, but also take informed patient preferences into account. And it's the last thing that we are still struggling with as an international community of cardiovascular experts. In my career, the beginning, I focused mainly on these two: scientific evidence and the patient's clinical state and circumstances. And later on, I tried to add to that informed patient preferences. So let me take you on that road that I took. I think over time, I was very much inspired by Malcolm Gladwell. I don't know if you know him, he's an author, and he talks about a lot about more general decision-making. And one of his famous TED Talks is about spaghetti sauce. So when I think of the best treatment, or when I think of the best timing of treatment, I always used to think of, okay, I need to either choose this or that. And it was rather black and white. And he made me realize that there's not only no perfect spaghetti sauce, but only perfect spaghetti sauces. The same applies to, for example, prosthetic heart valve selection. And that notion that it's not black and white, but actually I guess a rainbow of choices, like you see here, really changed the way I think about also my research. And I've moved away from randomized controlled trials because I think it's way more nuanced. So early on in my career, this is what I focused on. I tried to find out what the clinical outcomes were after different treatment options. And here you see the example of aortic valve replacement in non-elderly adults. And if we focus on the late outcomes here, you see for mechanical versus biological solutions in non-elderly patients, you see, for example, that the hazard of a reoperation in a mechanical valve is way lower than the hazard of a reoperation in biological solutions. Of course, because we have structural valve deterioration. And a mechanical valve is designed to last a lifetime. On the other hand, mechanical valves, we do know that anticoagulation-related complications are a big burden to patients and may lead to very major complications. And what you see here are the hazards, the annual risks of patients with a mechanical heart valve. And these are major bleedings that either kill you, major thromboembolisms that hospitalize you only. So these are big things. So when I ask my students in Rotterdam, the medical students, so what would you choose? One half comes up with a biological valve and the other one with a mechanical valve, because it's really personal. But we also need to realize that when we look at these numbers, it's all systematic reviews and meta-analysis. They apply only to countries with excellent healthcare systems. And especially when it comes to anticoagulation, we don't know what's happening in those systems where you do not have that tight control of INR. Same for aortic root surgery. We did studies in non-elderly patients looking at Benthal and looking at valve sparing. And again, that we see the same picture. Mechanical, it's thromboembolism and bleeding. Biological, it has to do with re-interventions. So how do you then use that to make decisions? Well, first and foremost, you need to put quality of life in the equation as well. And there is some evidence, and I have to say it doesn't apply to everybody, these are all averages, that quality of life is also affected by the choice that you make. This is an example, one of many, that looks at valve sparing versus composite replacement in aortic root aneurysm. And we see that when you look at Benthal, the composite replacement, we know that quality of life is compromised more than in repair. Valve noise is another thing that we often forget, but 40% of Benthal patients are severely disturbed by their prosthetic valve noise. Also, the fear that your heart valve may fail, interestingly, is higher in Benthal, where you would expect it to be lower because usually it's a mechanical valve, than in repair patients. And then if you ask patients about their overall condition, they rate it 5.8 out of 10 versus 7.6 out of 10 in valve repair patients. So quality of life is also something that you need to take into account when making those decisions. And again, it's different for different patients. So what I try to do in the first half of my career, tried to build really complex models like the one you see here. This is a microsimulation model that we built to do outcome analysis, to translate population estimates towards age and sex-specific patients. And basically what we did here is we would assume that in this simulation model that after valve replacement, you could either die or stay alive, and then stay alive until you eventually die and have no complications. But more often what happens in patients after valve replacement is there are some events over the years. And when you get an event, again, you can die as a result of that event, or you can get treatment. The treatment may kill you, but also it may be that you're alive after the event, and then you stay alive until you die, or you get more events over time. Well, that's basically what microsimulation does. And what I've been doing is I've been feeding big data into these models and trying to look to provide at least age and sex-specific estimates of what patients may expect over time. And I loved doing that until I tried to get it into the clinic, but I'll get to that. So basically what I've been doing, putting risks in these models, sometimes also quality of life estimates and even costs, and then look at different types of treatment options, what the outcomes would be for patients, and make predictions. Very simple to me now, but I understand complex to a lot of people, including our own surgeons. One of the things that let me give you an example what such a microsimulation model does. Here, this is an example of bioprosthetic valve replacement in non-elderly adults. And we calculate, what we do is, for example, for a 45-year-old patient, we would simulate 10,000 patient lives based on the input from the big data that we have. So we then create 10,000 lifetime trajectories of patients of 45 years, all the way until they die. And then you have a virtual data set, and based on that data set, you can actually calculate what the lifetime risk is, for example, of a re-intervention. If you get a bioprosthetic valve at the age of 45, and you can see it's quite high, it's like 76%. And these are estimates that patients can much more relate to, I thought, than estimates, oh, look at this Kaplan-Meier survival curve, and it's more specific. So also for all the other types of events that patients may incur, for example, bleeding is still something that happens because it happens first and foremost to all of us in the general population, but also patients with bioprosthetic valves may need anticoagulations for different reasons. And so this is an example of what we can do with that. And then I thought, well, I would love to bring this to the clinic because the vision that I have is, well, and let me skip a few more technical slides here for the sake of time. The vision that I have is that in the end, what I would like to do with this microsimulation methodology is not only look at that one particular decision in time that a patient is facing, but look at the different trajectories over the life of a patient, the different choices, in particular, if you have biological solutions implanted, and that you are actually able to think of different lifetime trajectories of treatment options over time. For example, you see this here in a newborn that here receives a balloon valvuloplasty, here an aortic valve repair, then a re-repair, then an autograft replacement, and then a mechanical valve. But what if we can play around with the different options and take a look at what that would mean for that patient throughout their lives? That's what I really want to go to. What we do for that is, again, we use meta-analysis, but we also use big data. And the Heart Valve Society Aviator database is one of those big data sets that we employ. And we like to work together with other centers across the world, for example, when it comes to ROS. And so this is what I'm going to work on for the next couple of years. But then again, I ran into the problem that it's not only about clinical outcomes, it's also about quality of life and patient preferences. So one of the things we've been doing more recently is with the International Consortium for Health Outcome Measures, is develop a standard set in partnership with patient organizations worldwide that not only focus on clinical outcomes, but also on aspects like quality of life, what you can see actually here, mental health and some more. So we're building on that and trying to implement that. But then again, I do have to go to Tol now, because Tol has been telling a story to me saying, hey, it is all about patient preferences. And again, I think Adam agrees with him on that. So I've also, in the second part of my career, been more involved in developing a shared decision support framework, for example, for people with Marfan. And if you ask people with Marfan what's more important, this is the answers that you get. Active and participatory lifestyle, more important for men than women. Avoiding anticoagulation. Getting the surgery over with as soon as possible. So that's not only a diameter we're talking about, and maintaining a life as normal as possible. And luckily, the guidelines are starting to pick up on shared decision-making. The desire of the informed patient is what they mention. But what exactly is shared decision-making? If I talk to clinicians, more often it's more about informed decision-making than truly sharing the decision. Informing patients about treatment options, involving patients and illicit preferences, and then ideally coming to a decision together if the patient desires so. And of course, we can use decision aids to support that process. There's some books in the past couple of years that I really recommend for you to take a closer look at. I think Eric Topol's book, The Patient Will See You Now, has really inspired me. And his newer book, Deep Medicine, builds on that. Victor Montori is one of the clinicians who's been asking for a patient revolutions for careful and kind care. And then there's, of course, the big data era that we have entered, where there's also calls for that. So we need to do this because patients do want to be informed. And as soon as patients are well informed, they want to be actively involved in the management of their disease. There are challenges, though. Doctors think they're good at assessing patient preferences, but actually they're not. That's what a lot of studies find out. And that's really scary because we mean well, but we need to be careful in translating our own values or placing our own values upon our patients. So that's an interesting observation. Patients have difficulties in understanding their disease and simple health statistics. That's another one. And so I'm very fast will go through these 3 simple questions that you can ask to measure how good numeracy or health literacy is in patients. And well, let's try to do them ourselves. So first and foremost, a person taking drug A has a 1% chance of having an allergic reaction. If 1,000 people take drug A, how many would you expect to have an allergic reaction? If you think of that, you probably know the answer. It's simple. It's 10 out of 1,000 people. The second question is, a person taking drug B has a 1 in 1,000 chance of an allergic reaction. What % of people taking drug B will have an allergic reaction? 0.1%. The third question, this is, I never thought this would be difficult, but imagine that I flip a coin 1,000 times. What's your best guess about how many times it would come up heads in 1,000 flips? Well, it's 500 out of 1,000. And then you think, why do people not know? 70% of the general population can answer the first question correctly. Only 25% can answer the second question correctly. And only 76% can answer the third question correctly. So if you then calculate how many people can answer all 3 questions correctly, that's only a few, you know. And then on top of that, only 72% of doctors is able to answer all 3 questions correctly. So there you are in your office and you're sitting there, yeah, you understand the numbers a little bit. and across the table is somebody who doesn't have a clue. These are challenges that we need to address. And I think it's getting better over time because there's more attention in education, also among doctors. The other challenge is that doctors often provide selective information. I'm happy to share a study I did among Dutch cardiologists and surgeons. It's really, really interesting to see how little information they actually convey to patients. And doctors have preferences too. And it very much depends, for example, when it comes to prosthetic valve selection, to which doctor you go. You may feel that yourselves as well. At least in the Netherlands, it's quite obvious from the study that I did. So these are challenges. However, it is important because informed patient preferences lead to more conservative treatment selection, less overtreatment, improved patient knowledge, improved patient involvement, and a better agreement between patient values and choice. Less regret. And what I also find important in these times, they are an important driver of containing costs in our healthcare system. So we've been building another decision aid some time ago, and we took a look at whether this decision aid could support prosthetic valve selection. And the question we basically asked is, does the use of this, how do you see it? Huh? Does the use of this support system lead to better care? Well, the answer in this randomized multi-center controlled trial was, yes, it does. The decision doesn't become easier, but patients have better knowledge, feel better informed, these are two different things, and experience less anxiety and depression and have a better mental quality of life. So these are ways that we can, or tools that we can use to support our shared decision making. Now I get to the last part of my talk. Go back to the operating room, and my third story is about a dinner in New York. I hope I still have time for that. Yeah, I think I do. And actually, it was during a Heart Valve Society meeting in New York, and we were at Times Square in the big Marriott hotel there, and I went out to dinner with 6 of my colleagues, 6 young cardiac surgeons. And the really cool thing was that there were 3 female and there were 3 male surgeons. And they had learned about me doing stuff besides cardiac surgery, because I've been involved in policy making when it comes to diversity and inclusion. And they said, well, Hanneke, why do you have this strange hobby? Look at us, you know, we're gender balanced, and that was quite diverse. I mean, people from different countries as well, originally. And I'm like, well, let me tell you a little riddle. And I told them that really famous riddle that you probably know, about the man and his son who drive in their car through the night, and they get into this terrible accident. And the father dies on the spot, but the little son has severe head trauma, and he's rushed into the operating room in the nearest hospital, and the neurosurgeon comes in, and he looks, and the neurosurgeon, I make a mistake myself. The neurosurgeon looks at the kid and says, I can't operate on this kid. It's my son. And it was quiet at the table. And then they're like, okay. And then one of them is like, okay, but this is a same-sex relationship. I'm like, well, it could be, but it also could be something else, you know? And then they came up with a really strange family relationship. And I don't want to go into details there. And I finally had to tell them that this neurosurgeon was a woman. And they're like, oh yeah. And ever since, it's been much more easy for me to explain to my colleagues why I do what I do, because the unconscious bias that we all carry along, not only with regard to gender, is really affecting also the way we organize ourselves. So, gender bias, but different biases, I think, besides gender, do affect, for example, science. We all know from the John and Jennifer study, that was a randomized trial done in the US in STEM universities, where senior faculty was asked to rate a CV of a junior researcher. we know that from that randomized trial where half of the CVs had John on top and the other half had Jennifer on top, that if people were asked to rate how competent John or Jennifer was, that John was always rated more competent. John was always rated more likely to be hired and also more likely to be mentored, be a high potential. Interestingly, also John would be offered a higher starting salary than Jennifer. And this is a randomized controlled trial. It's in our brains. It's okay. There's nothing we can do about it. It's how we are wired. The only thing we can do is be aware of it. But then again, in healthcare, we often move fast and do not have time to carefully think. And then the decision we make may not be always the right ones. What we see, the gender patterns in medical research organizations, and including our university medical centers, is a continued underrepresentation of women in higher positions, a lack of female role models, and I think this extends beyond gender. This is much richer than that. What we also see is we have inflexible working standards that were put in place in a time where mainly men were in the workforce, but times have changed. Promotion procedures are often non-transparent, and there is a hierarchical structure that's also not helping to change. Also, our implicit and explicit bias often leads to microaggressions or even worse, harassment. And on top of that, we do have, and it can be healthy, I know that, but we can also have an unhealthy, highly competitive and individualistic culture. So these are the things that we struggle with in the Netherlands, and I know different countries do that too. A very great paper written by a dear friend of mine, Kiki Lombards, from Amsterdam, a professor. She went to Abram Verghese in San Francisco, and together they wrote this in the New England Journal of Medicine that talks about the impact of medicine not being gender neutral, and talks about how important it is to understand and embrace a definition of physicianhood that's shaped by women as well as men, and that it has benefits not only for individual physicians, their organizations, but also for the care we deliver to our patients. Because it's important to realize, it's important to take it into account, because we do know that our gender is also somehow influencing the quality of care. I won't go into all details of this slide. Feel free to look up these publications, but this is one that you probably as surgeons ran into, I think about a year and a half ago, where this study found that if you are a female patient and you are operated by a male surgeon, that your risk of dying goes up by 1.3 times. And that's interesting to take a look at why that is happening. And that probably most likely has to do with the gender imbalance we still face in our institutions and the lack of more inclusive environments. And my hypothesis yesterday over dinner, it still is, my hypothesis is, it is probably has to do with the fact that due to gender bias, it's much more difficult for women to enter this specialty than it is for men. So only the very best get in. And I think it also would work the other way around. So, but we can discuss that. Why it is important, gender diversity in medical research, I think I'll skip the text here, but I go to the picture. I think it's because we need a diversity of perspectives. In the 21st century, it is all about team science, and it's also about having critical teams that come from different perspectives to really figure out that this thing is actually an elephant. In Europe, interestingly, the European Commission already in 2015 started a gendered innovations initiative, and they asked all institutions within the European domain to take gender balance in decision-making into account, to take gender balance in research team at all levels, to focus on that, and to also integrate the gender dimension into the content of research and innovation. And that's I guess what we need if we want to address positive change when it comes to gender equality. And now the most interesting thing, we also talked about that last night over dinner, is that now in the new Horizon program, the main funding program of the European Commission, you as a research institution can no longer apply for funding if you do not have a gender equality plan in place. For my center, that meant that we would lose about 50 to 60 million euros of funding every year. So the first thing that happened was we put on our website a formal document that said that we had a gender equality plan, and we started working. And it's actually quite nice if you look at what we work at. It's about work-life balance, organizational culture. It's about gender balance in leadership and decision-making. It's about gender equality in recruitment and career progression. And it's, of course, about integrating the gender dimension into research and teaching. And finally, I find that very important to name as well. It's also measures against gender-based violence. The past year, all the stories that come out of our system are really worrisome, and that needs to be addressed. And then we will create better systems for both men and women. So I hope that I have been able to get at least your attention with the 3 stories that I told. And I think in the end, what I hope is that sex and gender matter, not only in the content of research, but also in the way we organize ourselves, in the way we make decisions. And it will benefit everybody. It will benefit our patients, our systems, and the individuals that we are in these systems. Toward the future, I do hope that we move further beyond gender and see diversity, equity, and inclusion as a more holistic way forward. And that's what I truly hope that at least I can bring that from Europe to you, but you're probably also working very hard on that, that not everybody, that everybody is not only invited to the party, invited to dance, but also invited to choose the music to dance to. So I couldn't do this without some great, very diverse teams that I work in. And I wanted to highlight the Heart Valve Society community that I'm heavily involved in and our conference next year, but also my own PhD team. And I love working with these guys, and they produced a lot of the things that I showed you this morning. So thank you very much.
Hanneke, thank you so much for a wonderful 2023 Bigelow lecture. Okay, so we will open up the floor for some questions there. And Sylvia, I may ask you to sort of keep an eye on the Zoom room. So for those of you who are online with us virtually, I will get you to, you can either put your hand up and then Terry can unmute you, or type something into the chat. But in the meantime, anybody else in the live audience can pipe up as well. One thing I wanted to ask you, Hanneke, is that, for, decades, we've talked about the realization that our gold standard for evaluating therapies in medicine, the randomized clinical trial, is has some significant shortcomings in that, these patients in these trials are, always a very, very selected group, and don't represent in many ways the patients that we see every day in the clinic. And it seems like it's sort of shockingly recently that we've really sort of focused on how systematically different those patients are. And that, obviously the gender balance in the patients that we see in trials is very different. The sort of, ethnicity and, many other sort of, predictors outcomes, simply aren't representative. And so there's been a lot of work sort of focused on trying to make these things better. But, any thoughts that you might have on, how can we do better at this? In how we design trials, how can we enroll patients in them, how we interpret these results when our gold standard method of evaluation is in fact so seriously flawed.
Yeah, I do have some particular ideas about that. Well, first, it was my personal motivation to no longer do randomized controlled trials because they're so tedious and costly. I am Dutch. But at the same time, of course, my main motivation is the fact that we want to serve every single patient and all the diversities they bring in to our offices. And so my approach and also my motivation for starting big registries and collaborative efforts, gathering real life data, big data, is that of course there are registries, but with those registries come communities, and from those registries, you can still do randomized controlled trials to answer pertinent questions, and at the same time also assess how they apply to the bigger population of all patients that we serve. So I think registry embedded trials is a really nice way moving forward, where we take clinical practice as a starting point, and then within those communities that we've built in the registries, it's easy to ask those pertinent questions. But I think, and especially if I look at TCT, I think a few weeks ago, where there again, randomized controlled trial, how applicable is it to all our patients? That's something we need to move forward to in order to not only find answers about still the few black and white questions we have, but the rest, I think it's a full rainbow, and trying to apply our knowledge tailored to the individual patient, and that does not require randomized controlled trials.
Rutger.
Thank you for your presentation. Maybe a component of your talk on society matter, you had listed for women, was both high blood pressure, but also extremely low blood pressure. So how does extremely low blood pressure work in the genesis of aneurysm in the brain?
Yeah, and it does mean that at the time of diagnosis, these patients were basically wheeled urgently into the OR, more often than men. So that explains, yeah.
Good.
Thank you for your talk. It was very inspiring. I wanted to get, since you worked so much with big data registries, what your ideas are about the future of that. In Canada, we also have a multi-center national Aortic registry of aortic surgery. When we queried it many years ago when I was a fellow, we found that there was a big isolated difference in outcomes after aortic surgery. And then we re-queried it recently, and it disappeared too. So it's very dynamic. What happens, our outcomes change, the patients come, the patient profile changes over time. So there's like a temporal dynamic component. And so we reported now the updated data. And so what is your idea about the sort of intermittent reporting of these big data, which is something more nimble and dynamic, and you're able to share more real time what's happening with the registry?
Yeah, and the way I look at that with indeed all those big data that we have is that you need to approach it dynamically. And what we do back in the Netherlands with our national registry, and this is all cardiac surgery, is that we build our models and our reports on a scale that slides year by year. So we look at the past 5 years, and then the next year we move on and we adjust our reporting outcomes, and we also adjust the models that we use. The Euroscore model is that model that emerged from the UK. That's something that we far less use these days, but we'd rather build models on dynamic data sets, and every year we renew to keep it as up to date as can be. That's one thing. Another thing, what I do see in the future is that it's more about connecting different data sets and having data hubs where you can actually link in with your own data, and where perhaps also patients databases or patient input databases can also get in there. So it's much more about being dynamic and not only those really big registries, but you could also call it a data commons where all types of data, also biological, genetic data, etc., clinical data, patient-reported outcome data can come together and can be used as a whole. But that's something that's a work in progress. I know, for example, University of Chicago is really pushing the way forward with these types of collaborations within specific disease domains. And they've started in pediatrics because there it's very hard to get big data. And that's what I think is really hopeful. So, but it will take a couple, 5 years, and we'll get into that. Yeah.
David.
Thank you. Thank you very much. It's very thoughtful. I will also be very practical and maybe have started about the managing classic aneurysm and certified matter. There's all the data we looked at. If we purely are looking for the best outcome, is size the wrong thing to look at? Is that what you think? Looking at size is the wrong thing for the best outcome.
Well, look, I can't answer that question yet. I do know it's not the only thing we should look at. We do know, and I especially in the Electriades group paper that came out recently, a lot of the complications actually happen at smaller diameters than the diameter that we recommend surgery at. So that's one of the challenges that we have in trying to balance. So is there a perfect diameter? On top of that, there's other dimensions you can look at, and I used to Philip already wanted to also ask about that, but it's more complicated than that. So I hope that we can come with a set of predictive variables and also add to those the perspectives of patients, because quality of life of patients who walk around with their ticking time bomb is pretty lousy. So we also need to take that into account. And I hope it's a combination of things, and especially with imaging and the new ideas there are about other imaging ways of measuring the advancement of disease and the speed as well. That's one of the others, are what we're going to need to look at. Yeah. So for size matters, we only looked at those diameters, which in hindsight we're like, okay, should have done more. Yeah.
Rose.
I'm looking for your very relevant aspect of care using immunization. I often face this dilemma, like patient wants something which may not be the best option for a patient, particularly from minimally surgery. Everyone wants a minimally surgery, but the physician is even though this may not be the right patient for a minimally option, it's better to do it and mention. But then the patients many times are not very happy to hear that. So how do you deal with that aspect where there is some discrepancy between what you want to do for the patient problem? May be better for him.
Yeah.
And opposed to what the patient wants, which may not be the best option for that patient. I think that's what you should have. Again, you said that he may be wrong. But,
yeah, well, it's a tricky one, of course. Well, we've been taught not to do harm. So first and foremost, that's what we should stick to. On the other hand, we also see that patients tend to choose less invasive approaches that may not be as durable on the long term. And I think as the conventional approaches that we offer, and that's something that we encounter a lot. And on top, and then we need to realize that for patients, the value of avoiding events in the near future is much higher than the value of perhaps stuff that can happen in the distant future. So I think it's having that conversation with the patient and making the patient realize that if you choose, for example, a less invasive option and you go home the next day, instead you suffer 3 months because you need to rehabilitate, but then on the long term, I think that's the conversation you need to have. And if indeed the patient then prefers a treatment that does not align with your values, I would say, well, then perhaps you should say, well, perhaps you should go to my colleague for that. But I would not go along with that either. No, if you think it's really harmful. And then, of course, realizing the fact that we value things that are in the near future more than in the distant future, that's really something to discuss with the patient. Yeah.
Well, may I close with the last question, like, with, I think all developed a good idea of how things should be. So Hanneke, like, as, and this is partly an, are you an optimist or a pessimist question, like, how long do you think it'll be before a patient could expect to walk into a surgeon's office and we would say to them, okay, Mrs. Jones, like, as a 35-year-old woman with Marfan's, based on the data from large registries from microsimulation, here's what you, as a 35-year-old woman, could expect if we offered it on you today, and what would happen over the next 35 years to come. I'll explain to you what lifetime need for anticoagulation means, but you will tell me what a lifetime of anticoagulation would mean to you. How long do you think it's going to be before a patient might reasonably expect to be able to have that kind of experience?
Well, I hope we will, at least from my group, be able to come up with practical tools for clinical practice within the next 5 years. Because what I've been doing right now is I've been trying to perfect the microsimulation models, not only about the decisions that we take at this point in time, but also what I still need to do is allow them to think further into the future of the different options that come out of the decision that you take right now. And next to that, the patient portals, I just need to put it in there in a way that patients and doctors understand. So that does mean that they informed and evidence-based decision then supported by a shared decision-making process can be made. And that should be possible in the next 5 years.
Perfect. Like, I want to thank you again for a wonderful, thought-provoking, and very provocative 2023 Bigelow lecture. So, here's, we just wanted to present you a little certificate that so it commemorates you coming here and this. And then here is a book actually about innovation in cardiovascular surgery, particularly noticed here in Toronto. Again, this was written by a couple of our professors in their day, like also Hugh Scully in the audience, and Bernie Goldman, who we met last night, as well as Ned Shorter, who's one of our professors of the history of medicine. So thank you so much for coming, to Toronto. Like, it's so nice to meet you last night, and to hear your lecture today. Like, and for any of you who will be joining us at the symposium that will be running just down the street, like in the Fraser Elliott boardroom there, like where everybody's welcome. And we look forward to a very sort of stimulating discussion of many aspects of critical decision making in different areas of cardiac surgery. So, Hanneke, thank you so much for coming here.
Thank you.
And it's been a treat.
Yes. If you don't mind. Sorry, I said that. You gotta do it. You gotta do it.
Look, that was fantastic. Yeah, you can tell that from the level of engagement, like everybody's interested in it. Yeah, that was great.
Wonderful. Well, very much like you. Sorry for running a little bit over time.
No, I thought we were sort of dead on. It was perfect. Yeah.
Thanks very much,
Yeah.
Terry.
Thank you. Yeah. So that worked.
Yep, no problem.